All right. Well, thank you, everybody, for having us talk. It's really been fun to watch the prior sessions and get to hear from folks who previously I've only been on conference calls with or emails. So it's really been very exciting for us to get to sort of meet everyone. So today, Kofi and I are going to speak a little bit about respiratory rehabilitation for children with AFM. And now my slides aren't moving. Hold, please. All right, there we go. Okay, so many children with acute flaccid myelitis develop impairments in their respiratory musculature, and up to a quarter, or even in some series more, will develop a decrease requiring ventilatory support at some point during their illness, often in that nadir of symptoms that occurs in the first week. In the more recent reviews, that's been as high as 40 to 65%. Overall, most small series that look at kids a year or two out are demonstrating that between 10 to 20% will have a persistent requirement for support. I listed a few of them here, and you can see that they're pretty small numbers, but they tend to be in that range. The most recent one was actually a survey of that Facebook parent group that many of you are on, that was published in Pediatric Neurology this past January. And at 2 years after diagnosis, about 15% still had a requirement for ventilatory support. So what are the respiratory issues that children with acute flaccid myelitis are facing? So unlike an upper motor neuron spinal cord injury, where we have rigidity and decreased chest wall compliance, in AFM, there's just extreme flaccidity, very poor chest wall recoil. We see a lot of atelectasis developing. They have an impaired ability to clear the secretions from their airways, and then they have an increased production of secretions due to autonomic dysfunction. We also are concerned about ventilator-induced diaphragmatic dysfunction, just like anywhere else, where the skeletal muscles will atrophy due to deinnervation and lack of use. The increase of time spent on a ventilator will lead to increased diaphragm atrophy, and that we've seen occurring rather rapidly in children with AFM, which is consistent with what we can observe clinically in the remaining musculature as well. So this is just an example of a patient of ours who presented at 3 years old. This was his chest x-ray and admission. And you can see he has quite a bit of atelectasis, particularly in that right lower segment. And that's not at all an unusual presentation. So when children are admitted, what are our goals from a respiratory standpoint? Management of secretions, prevention of atelectasis, and then any activation of that diaphragm. We tend to put kids on SIMV ventilator settings. That helps to preserve whatever strength is remaining, because it does allow them to take these breaths over the vent as part of like respiratory muscle training. For children who are able to, we will do sprints off of the vent when they're ready. We like to see that they have, for the children who are able to generate a negative inspiratory pressure, that it's about a negative 20 to negative 30, depending on the age and their ability to do that. But even prior to that, having decreased pressure support, helping them to do more of the work of breathing themselves as they're able to do so, and thereby increase the remaining strength of their diaphragm. Traditionally, in pediatrics, we keep kids at a tidal volume of about 6 to 8 milliliters per kilo. In AFM, if we try to do that, we just see really increased rates of atelectasis. So we tend to run our volumes a lot higher. I would say that most of our patients are at around 10 per kilo, and I've certainly seen us go higher as well, depending on the individual patient. There's going to be another talk about diaphragmatic pacers, so I'm not going to discuss those at length, except to show that, to mention that I think there's a lot of advantage to starting DPS early if we're going to consider it, to help before that diaphragm atrophy has really developed, and to help recover both phrenic nerve function and maintain the muscle mass of the diaphragm itself. So I'm going to switch places with Kofi.
Hi guys, my name is Kofi Anoh. I'm one of the respiratory therapists here. With respiratory care rehab, as Dr. Melicosta has already introduced you guys to, the three main things we generally consider concurrently is mechanical ventilation, tracheostomy hygiene, and bronchial hygiene. Let's go. Okay. So with mechanical ventilation, you will need to optimize your ventilator settings. And generally, these settings tend to be their nighttime settings, what they end up calling it nighttime settings eventually. Optimizing your ventilator settings, you will need to decide whether you're going to use volume or pressure. Either way is fine. What we at Kennedy have realized is volume tends to work better for us because with the pressure, if they are manipulating them at the gym with them laying on their stomach, it causes tidal volumes to be decreased because of the pressure on the stomach, and then tend to cause respiratory distress. So volume tends to work very well for us. And like Dr. Melicosta said, 10 to 12 per kilo is what we generally kind of range from. Now, the one thing that you're going to have to also watch will be your PEEP. We generally tend to wean the FiO2 pretty quickly. So we find a decent PEEP that will give us enough expansion that will allow us to wean the FiO2 to 21% if we can, as soon as possible. Now, once we find our optimal ventilator settings and the patient is on, if they came with a diaphragmatic pacer, we condition them quickly with a diaphragmatic pacer, and then before we start conditioning them on the mechanical ventilation. If they didn't come with a pacer and they have some lung diaphragmatic function, we tend to jump on it right away and condition them with the mechanical ventilation by decreasing the rate gradually to about 6, and then we turn them into pressure support. While we're doing that, we'll be monitoring their CO2 gases occasionally to see if the ventilatory status is okay. Now, on pressure support, we monitor tidal volumes very closely, because that's if their tidal volumes are low, that means they need either adequate delta P. We need to increase it, and with time as they get stronger, we're able to wean the delta P. If we're able to wean the delta P to about 6 or 5 or 6, then we will check their NIF and see if they still have the muscle strength to be able to sprint off the vent. We also monitor their CO2 if we're going to sprint them off the vent, make sure that they're breathing and they're not in distress. We start really slow, sometimes a minute, and then gradually increase it if they tolerate it. Having said that, tracheostomy hygiene is one thing that people tend to overlook a lot. This helps with infection prevention as well. Now, you need to optimize your trach size. You have to find the ideal trach size for the patient, which sometimes can be a little bit challenging because each kid is different. And most of the time they tend to have really small necks. So depending on the patient, you would think the trach is too big. but actually it might be the actual size trach for the patient. If the trach is small, the leak becomes profound at night, because when they go to sleep, they generally ride the vent. And in doing so, you have a big leak and you don't get optimal ventilation. Because the idea at night is for them to rest and recuperate and get some lung inflation going. Since they're riding the vent, you can actually do total ventilation at night. And then during the day, you can let them work with the weaning and all that. So if you have a appropriate size trach, whether it's cuffless or cuffed, you tend to do better ventilation at night. At night, if you're going to inflate the cuff, if you're cuff and you're going to inflate it, use minimal occlusion volume, sometimes to a point where when the patient wakes up, they can also talk as well, because they tend to kind of get very anxious if they wake up and they can't talk. With tracheostomy hygiene, like I said, infection prevention is our biggest goal. Trach care daily and PRN, if by BID, that will be great if you have the time. Trach changes have to be done bi-weekly. Weekly is what we do at Kennedy, but some of the insurance agencies will only do bi-weekly. Oral care is very, very important as well. Generally, we do TID. BID will be minimum. This will help with reduce tracheitis if you do aggressive oral care. And then suctioning. Generally, we tend to use inline suction for these kids. If you're going to use out-of-line suction, you need to use sterile technique in order not to introduce any pathogens down your trach. So bronchial hygiene is another technique we use, and this is our goal is to mobilize secretions and then also recruit alveoli while we're doing that. Now, how do we do bronchial hygiene? Sometimes we use respiratory treatments, aerosol treatments, MDIs, bronchodilators, mucolytics, steroids sometimes. We do chest PT, we use the vest, and we do manual if the patient tolerates it. Depending on the patient, we may also use a pneumatic precursor as well. And cough assist is a big thing that actually inflates the lung, it mobilizes secretions and removes secretions as well. So we tend to encourage cough assist with our kids, and some of the kids actually become really, really attached to that. We've certainly used IPV or Medaneb for our kids. Most of them come from the ICU with IPV, and then we continue till we wean them off, and then maybe transition to cough assist and then the vest. Airway clearance, aggressive airway clearance is important with AFM cases because they tend to have a lot of secretions, and suction is your goal. And with that, I will turn over to Dr. Melicosta to conclude.
All right, thanks, Kofi. So some of this looks a little repetitive on my slide. I apologize from things Kofi said, but I really want to emphasize what we've sort of seen over the past 4 years since I've been taking care of these kids. When we first started, I think there was a tendency both among the medical team and the RT team to kind of think about pulmonary toilet the way we do with other kids who might be on a ventilator for other diagnostic reasons. And we learned pretty quickly that that is simply not aggressive enough. And so it's been a real strength, especially since Kofi's been here, where we are just being much more aggressive. I mean, almost like my kids with CF, right? I mean, where you really need to be super aggressive with the airway clearance. I'm a big fan of IPV. There's a number of trials that do show more improvement in atelectasis than with traditional chest physical therapy. We have been using that here with our AFM patients since 2016. I do find that the younger kids have a harder time tolerating it. It's more uncomfortable. Older kids who can sort of understand the reasoning behind it do better. So some of the younger kids, we don't do it as well, but I've found it to be very useful. We do inhaled steroids, bronchodilators. Again, the old school thought was sort of like, well, do we need the bronchodilators? Their lung sounds great today, doctor. But really, we're using it to promote that mucociliary clearance, not for bronchoconstriction. And then the cough assist, as Kofi mentioned. And so what's been the outcome of that? So in our survey that we did of our inpatient admissions, now this was a survey that we did in 2019. So it only, 2018. So it only covered kids up through December 31st, 2017. So it doesn't include kids from the 2018 wave of AFM. So we had 19 inpatient admissions up through that time. 10 of them required some degree of respiratory support on admission, whether that was being on a ventilator or needing CPAP or BiPAP at night. All of them received sort of respiratory care, as we've talked about. 8 of them were able to decrease the amount of support they required by discharge, whether that was switching from vent to CPAP or whether it was getting off during the day and still needing at night. And 2 of them were able to eliminate their need for respiratory support entirely. One of the other things that we pay a lot of attention to is discharge, that the care that we do here needs to kind of be continued at home. This is a lifelong, just like any other part of rehab, this will be an ongoing need that families have. So setting them up with cough assist, chest BT, that kind of stuff to have at home, and continuing those cares at home is super important as well. And with that, I'm happy to pass along to our next speaker, who's Courtney Porter from here at Kennedy. Thanks, everyone.